With this project, we now know that there's multiple resistance mechanisms to venetoclax-based therapy in AML. And this has been well documented by some of my former mentors, Dr. Courtney Donato, Marina Konopleva, and colleagues who have shown that certain gene mutations, so gene mutations such as FLT3-ITD, TP53, NRAS, KRAS, are associated with a shorter remission duration or more resistance and quicker relapse following ven-based lower intensity therapies, so hypomethylating agents with venetoclax. We also know there's, on the flip side of that, on the converse, there's mutations that are associated with ven sensitivity with prolonged durations of remission, NPM1, IDH1, IDH2. Separately from that, we know that AML phenotype. So we used to categorize AML based on differentiation state using the French, American, British, the FAB classification. And that's based on morphology. And that's really kind of fallen by the wayside. But there has been more evidence from Chen Pei and Dan Pollier and Craig Jordan out of Colorado that has shown that a monocytic phenotype or a monocytic AML cell is more resistant to ven-based therapy. And so we have genomic predictors of resistance, and we have phenotypic, genotype and phenotype that both predict resistance to ven. And so, as well as sensitivity with respect to phenotype. And so the question that we wanted to answer was, how do these interact with each other, and what is the differences in anti-apoptotic protein expression across these different disease states? Because a third mechanism of resistance that I hadn't really mentioned is that we know increased alternative anti-apoptotic protein expression is also associated with ven resistance. So venetoclax targets the anti-apoptotic protein BCL2, so increased MCL1 or BCL-XL is associated with ven resistance. So we leveraged the Beat AML database where we had ex vivo drug sensitivity to venetoclax, as well as RNA-seq defined AML phenotypes. We performed RNA-seq deconvolution using the Van Galen gene sets that have been previously published to identify AML phenotypes across a large population of AML samples. We started with 255 cases of AML. We whittled that down to the most primitive or immature AML phenotypes, and then the most mature AML phenotypes, which to compare, the most contrasting AML phenotypes or differentiation states, which left us with 151 patients, if my memory serves me correctly. And essentially what we found between the two is we first wanted to say, well, are certain genes that are associated with ven sensitivity or resistance enriched within different cell populations? And we found that in fact they are. More primitive AMLs had a higher frequency of mutations in transcription factor gene mutations, RUNX1, GATA2, CEBPA, as well as IDH1 and IDH2 mutations, while the more mature or monocytic skewed AML cases had an enrichment for signaling gene mutations in things like KRAS, NRAS, FLT3-TKD, PTPN11. And then there were mutations that really kind of ran the gamut. So for instance, TP53, which we know is a strong genomic predictor of resistance to ven, was actually more common in the primitive subtypes. And that may be that it is a more primitive leukemia type, and that might also explain why we see some early response with ven, but then ultimately resistance is acquired over time. But then the next question we wanted to answer was, well, within these different cell phenotypes, these different AML phenotypes, even though there's enrichment for certain gene mutations, do we observe differential ven sensitivity? And in fact, we do. We see that even within cases that are genomically defined, IDH1, IDH2, NPM1, very ven sensitive cases, that if the AML phenotype is more mature, dendritic cell or monocytic phenotype as the two specific groups we combined, that those patients had more resistance to venetoclax ex vivo. So this was all done ex vivo. And then the same is true for the more resistant subtypes. So if you had an NRAS or a KRAS mutation, most of those cases were more mature to begin with, but there were some cases that did have a more primitive phenotype, and those actually retained a little bit of ven sensitivity. And then when we incorporated anti-apoptotic protein expression levels across the cell differentiation state, we know there's been some very nice work that shows, for instance, IDH1 and IDH2 mutations increase dependency on BCL2. And so we first looked at different genomic subgroups, and we said, well, what's the expression of BCL2 across these subgroups? And indeed, IDH1 and IDH2 mutated AMLs had a higher BCL2 expression, so you can correlate it with genomic subgroups. But then the next question we asked is, well, is it really the genomic subgroups driving the anti-apoptotic protein expression, or are these molecular mutations just genomic markers of different cell differentiation states? And when we overlaid the cell differentiation state, what we found is that the cell differentiation state was actually a stronger driver of anti-apoptotic protein expression in actually ratios of different anti-apoptotic proteins. So we looked at MCL1, BCL-XL, and then actually another anti-apoptotic protein called BCL2A1, and overlaid this with BCL2 being the denominator. We found that with increasing expression of these three alternative anti-apoptotic proteins, decreasing BCL2 expression, that we saw a correlation with more mature myeloid differentiation in the AML samples and Ven resistance. And that was irrespective of the AML genotype. So in summary, what this abstract showed us is that certain genotypes are enriched within certain AML phenotypes, which seem to be the main driver of the anti-apoptotic protein expression that are driving Venetoclax resistance. Now, this will be something that we'll have to confirm prospectively in real clinical samples of patients treated with azacitidine and Venetoclax, because one of the limitations of this study is that we collected all these samples and performed ex vivo Venetoclax sensitivity testing, but majority of these patients were not actually treated with that regimen. And so it's a little bit more tough to draw strong clinical conclusions from that.